It's now my pleasure to introduce to you Dr. Susan Quaggan, a very good friend of the American Association of Kidney Patients. Dr. Quaggan serves as the Chair of Nephrology and Hypertension at the School of Medicine at Northwestern University. She's also the chair of the DKD Collaborative, the Diabetic Kidney Disease Collaborative, a new effort that's been founded in the past year by the American Society of Nephrology, which is funded by the National Institutes of Health and other sponsors. What Susan does at the DKD Collaborative is she pioneers the efforts that are aimed at identifying and slowing the progression of diabetic kidney disease and laying the research foundation for new breakthroughs in medicine. She serves on the American Society of Nephrology Council. She's internationally recognized as a research leader, but most importantly to patients. She's a champion of patients. She respects their preferences and their insights, and she's a strong believer in having patients side by side with researchers in order to identify breakthroughs. A good friend of the American Association of Kidney Patients, please listen to her words, because very few people have the optimism that she does, and her ability to impart it will be very inspiring to you. Dr. Quaggan, go right ahead.
Hi. Well, thank you very much, Paul, for that wonderful introduction. And I want to thank both Paul Conway and Richard Knight for the wonderful invitation to be with you today. Mr. Knight and Mr. Conway asked me to present today on a new initiative that is happening at the American Society of Nephrology that I am very excited about. It focuses on diabetic kidney disease, and we are known as the DKD-C. To set the scope of the issue, we're in the midst of a pandemic right now in very difficult times. But preceding this pandemic, I think everybody in the audience knows that there's been a long-standing epidemic of diabetes throughout the world, and there will be one for many, many years and decades to come. Now, this is an old slide that I've chosen to show. And in 2015, there was an estimated 415 million people in the world living with diabetes. And said another way, that is 1 in 11 adults. If we focus on the United States alone, there is an estimated 48 million individuals living with diabetes. Now, the majority of people with diabetes have type 2 diabetes. However, irregardless of whether you have type 1 or type 2 diabetes, 30 to 40% will develop diabetic kidney disease. And this is a staggering number. And in fact, many people in the public really don't recognize the impact of kidney disease in diabetes. So, what can we do to prevent kidney disease and diabetes? And this slide talks about sort of standard of care. This standard of care existed when I was a nephrology trainee, and that is now 30 years ago. And so for a number of decades, the recommendations really did not change very much. There is no cure for diabetes, and there is no cure for kidney disease and diabetes. However, there are ways to slow the progression of kidney disease and to slow the progression to kidney failure. And I think most people know that these things include excellent blood sugar control, and this is a combination of diet, exercise, and medications. Excellent blood pressure control. And in particular, there is a class of blood pressure medications that have a long name. They're known as renin-angiotensin-aldosterone system inhibitors, and this includes the ACE inhibitors and the ARBs, the angiotensin receptor blockers. And I can tell you, I remember 30 years ago, sitting in a classroom, hearing the results of this landmark trial that showed for the first time a new type of drug that could really dramatically slow the progression of kidney disease in patients with diabetes. Incredibly exciting, and I can still visualize it. It had such an impact on me. Despite us knowing for over 30 years now that this therapy is really beneficial, a recent study showed that patients with diabetes who should be receiving these medications as standard of care, in fact, only 30% of patients were receiving them. So this is very, very this is a real issue, and we need to understand why these therapies haven't been adopted, why they're not prescribed, and why they're not getting to the patients who need them. In addition to these therapies, certainly looking after heart risk factors, looking after lipids and other things are also important in diabetes. So this is one real issue, getting the medications that are needed to patients. The second issue, which is actually very exciting and is energizing, is that there are a number of new therapies that have now entered the market. And it really is time to change history of diabetic kidney disease. Over the past few years, there have been a number of new therapies that target the kidney specifically. In particular, a class of medications known as SGLT2 inhibitors or sodium glucose transport inhibitors that were originally designed and discovered through research. And the thought was it could help blood glucose or blood sugar control by promoting sugar loss in the urine. However, the clinical trials done in thousands of patients showed that it's not really good at lowering blood sugar. However, they are tremendously powerful at protecting the kidney in patients with diabetes. So a truly kidney-targeted therapy. In addition, these drugs also have profound and powerful effects on protecting the heart in patients with diabetes. In addition to this really exciting new class of drugs, there are a number of other new players on the scene, and these include GLP-1 agonists, GLP-1 receptor agonists, a new study that was stopped early because of positive effects looking at finerenone, which is an aldosterone mineralocorticoid receptor inhibitor. And all of these are showing powerful protection of the kidney and also of the heart in diabetes. And interestingly, it appears that the SGLT2 inhibitors have additional effects even in patients who don't have diabetes but also have kidney disease. Based on all of this information, the scope of the problem, we know there's an epidemic of diabetes, staggering numbers of individuals who have diabetic kidney disease. We know that for the past 30 years, patients with diabetes have not been getting the best care. So now with these new therapies, there was a real passion, a real desire to ensure that we get these new therapies to patients who need them. So the American Society of Nephrology launched a task force known as the Diabetic Kidney Disease Collaborative. And I show an image here of all the members of this task force, which I have the privilege to chair. On the left-hand side, I think known to many of you here, Dr. Patrick G., who is an ambassador and on the board of directors at AAKP and is our patient voice and advocate on the task force. David Cherney, standing next to him, who is a nephrologist at the University of Toronto, world-renowned diabetes and diabetic kidney disease researcher and physician. Next to him is Dr. Catherine Tuttle, who is both a nephrologist and a diabetes doctor and endocrinologist, and she works in Washington State, and another expert researcher and physician in diabetes and diabetic kidney disease, Alan Kleiger, who has been on the task force of numerous committees at the American Society of Nephrology, including the COVID task force, bringing his expertise. I'm standing next to Alan. Next to me is Ray Harris, who is the past president of the American Society of Nephrology and the Kidney Health Initiative co-chair, nephrologist at Vanderbilt. And then finally Chip Brocious, who's the chief of nephrology at Arizona, also a researcher and nephrologist interested in diabetic kidney disease. So when we launched this collaborative, we had a charge, and the charge is to develop strategies to promote the rapid and universal adoption of these powerful new therapies, such as the SGLT2 inhibitors that I talked about a couple of slides ago, to make sure they are provided to all patients who need them. So our objectives to, accomplish this charge is to empower and engage nephrologists and the kidney care team so that they prescribe these new therapies for patients with diabetic kidney disease. We want them to take charge. In addition, we want to promote partnerships that are absolutely critical between nephrologists and other healthcare providers that look after patients with diabetes. This includes primary care physicians, endocrinologists or diabetes doctors, and heart specialists or cardiologists to truly encourage a team-based approach to patient care, which we feel is so important. To develop educational resources for patients, for healthcare providers, to ensure there is a rapid adoption of these new powerful therapies. And also to work with policy and regulatory agencies as well as payers to make sure that it's possible for patients to receive these medications and for all patients to receive them. So how are we doing this? So the task force you saw, you aren't seeing an incredible group of staff, people at ASN who help bring this all together. Over the past couple of years, this task force has met weekly on virtual meetings and more recently every other week. We hosted an in-person strategy conference in Washington, D.C. in January of this past year, and stakeholders who were present were patients, the National Kidney Foundation, our partners at AAKP, nephrologists from around the country. There were representatives from payers, from health systems, from the FDA, from human health services, from pharmaceutical companies, and our research partners at the National Institutes of Health. And out of this very energizing meeting, we've developed a white paper with a long list of deliverables and a description of subgroups to help us accomplish the charge. And this includes an educational materials and advocacy subgroup, a patient-oriented project subgroup, a pilot project subgroup, meetings and collaborative subgroup. We are in the midst of 3 webinars. The first was hosted in August, and this was spearheaded by Patrick G. With a number of patients and nephrologists and endocrinologists talking about diabetes and kidney disease and management in the time of COVID-19. And if you didn't get an opportunity to log into that webinar, it's available on our ASN website and freely downloadable, and it was phenomenal. Our second webinar is scheduled for September, and this one is going to focus on nephrologists and the kidney care team to really empower and engage the kidney care team to adopt these therapies, start prescribing them, and to talk to patients about them. And in December, we're going to have our multidisciplinary webinar inviting our cardiology heart colleagues, endocrinologists, to discuss the newest standards of care to ensure that we slow the progression of kidney disease and diabetes, and also slow the progression of heart disease in our patients. What I've talked about today, and I can't tell you how excited I am about all of these new therapies. They are going to transform the history and the course and the trajectory of kidney disease and diabetes. However, despite their ability to really dramatically slow the progression of kidney disease and prevent patients from ending up on dialysis for years and over a decade, we can't stop. We're only going to stop when we cure diabetes and when we cure kidney disease. So we need to continue to work together, partners with AAKP and ASN, to advocate for more kidney-focused funding with our NIH and NIDDK partners. And I can't tell you, and I think everybody here knows, that Congress listens to patients. And I would also encourage you as patients and providers to consider enrolling in clinical trials and to be sure to check out that clinicaltrials.gov website. And it's only when we get great representation in these clinical trials will we really be able to make an impact in this disease. So my final slide, I just want to finish and say that partnering with patients is absolutely essential for success of this initiative, of this collaborative initiative. Patients absolutely have the most powerful voice. And if you have any interest in getting engaged with the DKDC task force or learning more about it, please reach out to us and continue to work with AAKP, or you can email the Executive Vice President, Todd Ibrahim, at ASN. I absolutely know that together we will win this good fight, and together we are all going to sock it to kidney disease. Again, I want to thank Paul and Richard Knight for the incredible invitation to participate in this very important meeting. Thank you.
Thank you very much, Dr. Quaggan, for your presentation. I have two quick questions for you. As a medical professional and as a researcher, can you tell me what impact patient stories and the stories of patients trying to manage their diabetic kidney disease have had on you, and the insights that you bring to the research that you do for the DKD Collaborative? Thank you.
Yeah, that is a great question. Thank you, Paul. You know, it's interesting because I started out my career with no thoughts of doing research, and I loved medicine. I went to medical school straight out of an undergraduate program, and absolutely loved clinical medicine, and started out on nephrology, fell in love with kidney medicine first and foremost. But I think it was in my first couple of weeks as an intern and throughout my training where it became absolutely clear that we need to do so much more for our patients with kidney disease, not only diabetic kidney disease, but all kidney diseases. We know that diabetes is the leading cause of kidney failure worldwide, and I can recount a specific story. I remember rounding in our dialysis unit back in Toronto, and there was a favorite patient of mine. He'd been a football hero in Canada. His name was also Paul. He lost his kidneys to diabetes. He lost his vision to diabetes. He lost both legs to diabetes, and this was, you know, a number of decades ago. However, he was an inspiration, and I realized I needed to retrain, go back, learn how to become a researcher, which I did after clinical training. And now I have a career where I'm able to bring both of them together, do both research and continue to see patients. I think that's what most of us do when we go into the lab, inspired by incredible stories and incredible patients along the way.
My second question, Dr. Quaggan, is this. Based on the DKD Collaborative and the research that you're doing in diabetic kidney disease, can you tell me whether or not in this next generation of nephrologists, is there a sense of excitement that perhaps in their lifetime they'll be able to bend the curve of diabetic kidney disease, especially how it disproportionately impacts minorities and at-risk patients? Do they sense optimism? Because I know that patients are thinking like that. I just want to make certain that the nephrologists are. Thank you.
Another great question. Thank you, Paul. And just as patients continue to inspire me every day, the next generation of kidney care providers and kidney researchers are, you know, another incredible source of inspiration. So, you know, throughout my career, I've been privileged to have over 50 trainees come through the lab, and, you know, teaching medical students, bringing high school students. We have a program where high school students from various Chicago neighborhoods are able to come in for an internship. And it always amazes me, their energy, their enthusiasm, their brilliance. They look at problems in a different way. I am also inspired by their desire for health equity, for social justice. And, you know, I could tell you a specific story. I've got a medical student in the lab right now. He's a full-time medical student, but he comes in on his nights off and his weekends to come in and study sort of the role of these SGLT2 inhibitors, trying to figure out why they're so powerful in protecting the kidney, with a hope to identify and develop new therapies. I am truly inspired by this next generation. I think they're going to make a huge impact, and I would say to anybody who is interested in a career in medicine, I can't think of a better subspecialty than nephrology if you really want to make an impact on health equity, not only within the United States, but globally.
Thank you, Dr. Quaggan. And rest assured, the American Association of Kidney Patients will do everything we can to educate our members on DKD and the collaborative, and to make certain that they're ready and prepared and asking to participate with you in your research. Thank you very much again for being at our annual meeting. It's now my real honor to introduce to you Dr. Dominic Raj. Dr. Raj serves as the Chief of Kidney and Hypertension Medicine at the George Washington University School of Medicine and Health Sciences. Dr. Raj is a very good friend of kidney patients, and he also serves as the co-chair of our annual GW AAKP Kidney Disease Innovations Global Summit. He's an international leader in kidney disease and kidney disease research. He has a very fine specialty area in diabetic kidney disease, and he's here to present also on the issue of treating patients with diabetic kidney disease, new advances in the field, and what he sees as points of optimism. Without further delay, Dr. Raj, go right ahead.
I'm Dominic Raj. I'm the Chief of Nephrology at the George Washington University School of Medicine. I will be giving a brief glimpse of the recent advances in diabetic kidney disease. I wish to express my sincere gratitude to the AAKP leadership for inviting me to speak at this prestigious meeting. Let me begin with some sobering statistics. The number of people with diabetes has increased from 108 million in 1980 to 422 million in 2014. Diabetes prevalence has been rising more rapidly in the middle and low-income countries, straining the meager resources they have. Diabetes remains a major cause of blindness, kidney failure, heart attack, stroke, and lower limb amputations across the world. In 2016, an estimated 1.6 million deaths were attributed to diabetes. The United States Renal Data System reports that diabetic kidney disease is the leading cause for end-stage renal disease. However, it is important to remember not all kidney diseases in diabetes is due to diabetic nephropathy. They could also have due to kidney disease unrelated to diabetes. The natural history of diabetic kidney disease has been well described. In the beginning, diabetic patients have increased glomerular filtration, which is a measure of kidney function. At this stage, the functional unit of kidney called glomeruli are actually enlarged. This is followed by a gradual decrease in glomerular filtration rate, which is accompanied by progressive increase in protein in the urine. There is a progressive destruction of kidney due to accumulation of altered cellular matrix, shown as darker material and thickening of the capillary loops, leading to progressive irreversible damage due to fibrosis. Monginson et al. In 1983 described the stages of diabetic nephropathy in type 1 diabetes. Stage 1A is hyperfiltration with GFR more than 150 ml per minute per 1.73 meter square. Stage 2 is silent stage of structural changes characterized by mesangial expansion and basement membrane thickening, which I showed you earlier. Stage 3 is incipient nephropathy characterized by microalbuminuria with albumin excretion between 30 to 300 milligram per day. Stage 4 is overt nephropathy with dipstick positive albuminuria with albumin excretion more than 300 milligram per day. During this phase, the GFR or the kidney function starts declining at the rate of 1 ml per minute per month if untreated. Stage 5 is advanced CKD and end-stage renal disease. Evidence from Pima Indians who have type 2 diabetes indicates that the natural history of diabetic nephropathy is not different in type 1 and type 2 diabetes patients. Microalbuminuria is regarded as the first clinical sign of diabetic nephropathy. However, urine albumin excretion fluctuates widely from day to day, so one urine examination is insufficient. For a confident diagnosis, albumin excretion should be abnormal in a minimum of 2 of the 3 urine samples collected over 3 months period. It is now believed that about 30% of the patients with diabetes develop nephropathy, that is microalbuminuria. Only about 50% of the microalbuminuria patients progress to overt nephropathy, and about 20% of them progress to end-stage renal disease. Slower progression reported in recent years is possibly secondary to better glycemic control, lipid and blood pressure control. Our understanding of the natural history of diabetic nephropathy has undergone a lot of change in recent years. Older view was rigid, with the unidirectional progression from micro to macroalbuminuria, evolving to end-stage renal disease. Now we understand that patients with micro and to some extent macroalbuminuria can actually become normal. We are also seeing many diabetic patients have no albumin in the urine and yet progress to end-stage kidney disease. A substantial number of patients with diabetic kidney disease present without albuminuria. About 30 to 50% of CKD patients with type 2 diabetes present with normo or microalbuminuria. It is more frequent in women. About 60 to 80% of patients with diabetic nephropathy have diabetic retinopathy, that is eye involvement due to diabetes, which is infrequent in non-proteinuric diabetic nephropathy. Histologically, 40% of these patients have tubulointerstitial disease and vascular lesions, and 30% have normal renal architecture, which is distinctly different from the classical diabetic nephropathy, which affects the glomeruli. In these patients, angiotensin converting enzyme inhibition is relatively inefficient. So it also affects the way in which we treat these patients. Diabetic nephropathy has a heritable component supported by clustering of diabetic nephropathy within families. However, more than 2,000 papers have been published on genetics of diabetic nephropathy with conflicting findings, reflecting genetic and phenotypic heterogeneity. It is becoming clear that complex diseases such as diabetes involve the interaction between environmental and lifestyle factors and inherited genetic susceptibility. This interaction is called epigenetics, that is above genetics. An interesting observation was made by the Diabetes Control and Complication Trial investigators called the DCCT trial. DCCT included 1,441 patients with type 1 diabetes who were assigned to intensive glycemic control or blood glucose control or to a conventional therapy. Intensive therapy reduced the occurrence of microalbuminuria by 39% and albuminuria by 54%. This is not the end of the story. After completion of the DCCT, these patients were followed for additional 8 years as a part of the EDIC study. During the EDIC study, blood glucose levels were comparable between the two original treatment arms. And yet, patients originally assigned to the intensive control of blood glucose arm during DCCT continued to have lower prevalence of albuminuria, even though the blood glucose control in the original treatment and the control arm were no longer different during EDIC. They called it the memory effect. Similar findings were reported in studies involving type 2 diabetes. So what is memory effect? Chromosome has to be in an open, relaxed form for the gene to be transcribed. Chronic exposure to high glucose leads to heritable changes in chromosome configuration and gene expression, which is called epigenetics. These changes are memorized as epigenetic memory in the cell. When the second stimulus occurs, cells with epigenetic memory can respond to the stimulus promptly and in larger magnitude by gene transcription. So you may have the genetic predisposition, but you can still control your genes by behavioral modification through epigenetics. Inflammation seems to play a central role in progression of diabetic kidney disease. Chronic exposure to high glucose damages kidney cells, resulting in cell injury or cell death, releasing damage-associated signaling molecules called damp. These activate inflammatory cascade in the kidney. Chronic unresolved inflammation result in progressive kidney fibrosis. So where do we stand with treatment of diabetes and its complications? What about blood glucose control? The ACCORD study randomized 10,000 patients to receive intensive therapy targeting a A1C level or blood glucose A1C level of about 6% or to standard therapy targeting a blood glucose A1C level of 7 to 7.9%. The primary outcome was a composite of non-fatal myocardial infarction, non-fatal stroke, death from cardiovascular causes, which were not different between the two arms. Higher mortality in the intensive therapy group led to discontinuation of the intensive therapy after a mean period of 3.5 years of follow-up. Based on these results, the KDOQI guidelines recommend a target A1C of 7% to prevent delay progression of the microvascular complications of diabetes, including diabetic kidney disease. They also recommended not treating A1C to a target A1C target of less than 7% in patients with risk for hypoglycemia or low blood glucose. Does intensive control of blood pressure benefit in patients with diabetes? The second part of the ACCORD study, about 4,700 patients with type 2 diabetes were randomized to a blood pressure target of 120 millimeters of mercury or to 140 millimeters of mercury. The study showed that the annual rate of primary outcome of cardiovascular events was not significantly different between diabetics randomized to 120 or to 140 millimeters of mercury. Can angiotensin receptor blockers prevent composite cardiorenal endpoints in individuals with diabetes? The Renal study involved 1,500 patients randomized either to ARB, losartan, or to a placebo. Losartan decreased the risk of doubling of serum creatinine by 25%, end-stage renal disease by 28%, and ESRD or death by 20%. Proteinuria also decreased by 35%. The current standards for medical care in diabetes was released in 2018. It recommends that most patients with diabetes and hypertension should be treated with a 2-year systolic blood pressure goal of 140 millimeters of mercury and a diastolic blood pressure goal of 90 millimeters of mercury. Lower blood pressure targets, that is 130 by 80, may be appropriate for individuals with high risk for cardiovascular disease. They can be achieved without undue treatment burden. If they can be achieved with undue treatment burden. Hypertensive patients with diabetes and CKD should be treated with the angiotensin converting enzyme inhibitor or ACE or an ARB, usually in combination with the diabetic. These two medications are not usually combined together. We recommend not using an ACE or an ARB for a primary prevention of diabetic kidney disease in normotensive, normoalbuminuric patients with diabetes. So do not use these medications in patients who have no high blood pressure or who do not have albumin in the urine. Several studies have tested many drugs targeting pathways shown to be involved in progression of diabetic nephropathy, including protein kinase, transcriptional pathways, and inflammation. Unfortunately, many were ineffective or were stopped because of adverse effects. Non-coding RNAs, such as microRNAs, are not transcribed to protein, but they seem to play an important role in regulating gene expression. They are important in cell-to-cell communication and have been shown to play a vital role in regulating fibrosis, which is key in diabetic nephropathy. In a NIDDK-funded study, we are examining whether microRNAs could be used to identify patients at risk for rapid loss of kidney function and whether it could be used as a therapeutic target to prevent kidney fibrosis in patients with diabetes, including diabetic patients. This is the renowned statue of Goddess of Victory in Paris Louvre Museum. Are we ready to declare victory in arresting the progression of diabetic nephropathy? There seems to be some hope. Proximal tubule in the kidney has the sodium glucose co-transporter called the SGL2. Co-transporter means they are transported together. This is responsible for reabsorbing about 90% of the glucose that is filtered by the kidney. Sodium is also reabsorbed along with this glucose, as I mentioned earlier. Decreased sodium delivery to the distal tubule causes afferent arteriole to dilate, promoting hyperfiltration, which, if you recall, is stage 1 of diabetic nephropathy. When sodium glucose co-transporter is blocked, glucose and sodium are excreted and the afferent arteriole is constricted, and hence there is no hyperfiltration. SGL2 inhibition results in reduction of plasma glucose, lower blood pressure, prevent hyperfiltration in the kidney, and also reduces body weight. Recently, several studies have been conducted confirming the beneficial effect of SGL2 inhibition. Meta-analysis or combined data analysis of 3 of such randomized controlled trials involving 34,000 patients showed that SGL2 inhibition lowers the A1C by about 0.5 to 0.8%. In addition, it also induced 2 to 3 kg weight loss. SGL2 inhibition lowers the cardiovascular events by 11% in those with underlying atherosclerotic vascular disease. They reduce the risk for cardiovascular death or hospitalization for heart failure. There is about 45% reduction in progression of CKD. So I showed you the beneficial effect. So what are the risks? The risks include genitourinary infection or urinary tract infection, lower limb amputation, bone fractures, and volume depletion causing acute kidney injury. One important observation is that patients may experience so-called euglycemic ketoacidosis. These patients will not have a high blood glucose, but they will have ketoacidosis. Glucose does not rise high enough in these patients due to SGL2 inhibition because of endogenous insulin and loss of glucose in the urine. Another new oral hypoglycemic agent targets incretins. Incretins are released from the gut in response to food ingestion, so it is more physiological. Glucagon-like peptide 1 or GLP-1 is an incretin, which mediates about 50 to 70% of the total insulin release in response to oral glucose load. Incretins are rapidly degraded by dipeptidyl aminopeptidase 4 or DPP4. GLP-1 analogs bind and activate GLP-1 receptor releasing insulin. DPP4 inhibitors prevent degradation of GLP-1, thereby increase endogenous insulin. The leader study involved about 9,340 type 2 diabetes patients with high risk for cardiovascular disease who were randomized to liraglutide or a GLP-1 analog or a placebo. The primary composite outcome of time to occurrence of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke was reduced in the liraglutide group. Another meta-analysis of GLP-1 agonist data from 7 trials involving 56,000 patients was published recently. It suggests that GLP-1 agonists reduce major adverse cardiac events as well as all-cause mortality and risk of admission for heart failure. It reduced the risk of worsening kidney function, mainly due to decrease in development of macroalbuminuria. no major adverse events were observed. So it is safe and has some cardiovascular benefits. The DPP-4 inhibitors prevent the breakdown of GLP-1 and increase the endogenous insulin. Carmelina study randomized about 7,000 patients with eGFR between 15 to 75 ml per minute, either to linagliptin or to placebo. Linagliptin, a DPP-4 inhibitor, had a neutral effect on cardiovascular and kidney outcome. Thus, it is safe but not different from placebo in terms of renal and cardiovascular outcomes. How do SGLT2 inhibitors, GLP-1 agonists, and DPP-4 inhibitors compare? A meta-analysis of 236 trials randomizing 176,000 participants concluded that the use of SGLT2 inhibition or GLP-1 agonist is associated with lower mortality than DPP-4 inhibitors, a placebo or no treatment. Of the three classes tested, SGLT2 inhibition may be preferred over the incretin-based therapies. In line with the current evidence, the 2018 consensus report from the American Diabetes Association and recently from KDIGO recommend metformin is the first line of treatment unless contraindicated. I will talk about it later. They recommended SGLT2 inhibitors for patients with CKD so long as the GFR is more than 45 ml per minute, and is strongly recommended in those with heart failure or atherosclerotic vascular disease. There is some data that the use of metformin is associated with lactic acidosis, especially in those with lower level of kidney function. So what is the FDA guidelines for using metformin? In patients with GFR more than 60 ml per minute, use it with annual monitoring for lactic acidosis. If GFR is between 45 and 60, metformin could be used with monitoring of kidney function every 3 to 6 months. In those with GFR less than 30, use is contraindicated. It is advisable to discontinue metformin when though there is an anticipated risk for acute kidney injury, such as surgery or any other procedure. To summarize, clinical presentation of diabetic kidney disease is changing. Gene-environmental interaction is important in mediating diabetic complications. Target blood pressure and glycemic control should be individualized in diabetes. Cautious glycemic control and judicious use of ACE and ARB are recommended. SGLT2 inhibition and GLP-1 agonists should be considered in patients with atherosclerotic vascular disease, heart failure, and CKD. Thank you very much for listening. I hope there is some interesting questions.
Thank you very much, Dr. Raj, for your presentation. And as you know, a huge emphasis is placed on diabetic kidney disease in terms of educating patients. But I wanted to get your insights on whether or not the advances in diabetic kidney disease may give rise to greater hope among caregivers, since caregivers taking care of patients with both kidney disease and diabetes are in for a pretty tough spot sometimes, and a lot of them come to AAKP and say they're having a real challenge. Where do you see the points of optimism on that?
One important way by which the patients could be made aware of advancement is working with AAKP. See, this lecture is partially meant for, it has so much information that it is adequate for a provider, and it also gives you sufficient information for the patient. The most important thing is, after you listen to this, when you have the question, go to your provider and say, they said like this, is it true? I heard such information from the AAKP meeting. Could you explain to me, is this the right choice of medication for me? What we do at GW is, we have a CKD education clinic in which we specifically teach the patients the lifestyle modification We also have a separate so-called dietary clinic in which we tell them how to adjust their diet, which will enable them to control not only the blood glucose, but also control the blood pressure and also progression of kidney disease.
Thanks, Doc. Another question for you. Can you tell us, for patients that have DKD, how vulnerable are they to COVID-19, and are there any particular issues with COVID-19 and diabetic kidney disease patients that they should be aware of and that their caregivers should be aware of?
The reason is patients with diabetes or diabetic kidney disease are more immunocompromised than a patient without diabetes. As I mentioned to you, they have immune dysregulation, which results in inflammation. So if you look at COVID mediates a significant part of its damage by activating inflammatory cascade. So you have two risk factors, actually three: COVID, CKD, and diabetes. In fact, analysis of data from COVID registry show that diabetes is an independent risk factor for death due to COVID.
Thank you so very much, Dr. Raj. And again, we appreciate your time. Dr. Raj has been very generous to the American Association of Kidney Patients, involving the full span of the George Washington University School of Medicine and Health Sciences as co-sponsors for our annual Global Summit on Kidney Disease Innovation, and here today as a participant in our discussion about diabetic kidney disease in the overall context of the great collaborative that is taking place, the Diabetic Kidney Disease Collaborative, and other initiatives to bring hope and, most importantly, medical and research breakthroughs to patients and to the professionals who take care of them. Again, Dr. Raj, we appreciate it. You're a true champion of patients, and it's fine to work right along beside you. Thank you.